Okay, so I'm going to be talking today about neurotoxicology to try to fit in with the theme. And just as an overview, we'll start with the antagonistic effects between glutamate and GABA in the brain. We'll talk about spinal cord and neuromuscular junction and the role of glycine and acetylcholine. The autonomic toxidromes, cholinergic and anticholinergic, and adrenergic, also known as sympathomimetic, and then a little bit on toxic neuropathies. So in the brain, there is a balance between GABA and glutamate, where GABA is our main inhibitory neurotransmitter. Glutamate is our main excitatory neurotransmitter. If you have too much GABA, you have coma. If you have too much glutamate, you have seizures. If you have a perfect balance between the two, that's what we call consciousness. So that's basically when we have that exact amount of those two things. There's also an intimate relationship between GABA and glutamate in that glutamate is actually converted into GABA by glutamate decarboxylase. So the neurotransmitters are actually directly converted between each other. And when we say that GABA is an inhibitory neurotransmitter, what does that mean? Well, the GABA channel is linked to a chloride channel, and chloride, when it comes into the cell, makes it more negatively charged and less likely to depolarize. So that's basically that inhibitory effect. And there are a lot of ligands that combine to different parts of the GABA receptor. We think a lot about benzodiazepines and barbiturates. Steroids also have an effect on the GABA receptor. There are also things that are antagonists to GABA, like the picrotoxin binding site is where our TCAs bind and cause seizures. In terms of glutamatergic drugs, these are excitatory neurotransmitter effects because glutamate is linked to a calcium channel. And when calcium comes into the cell, it makes it more positive and more likely to depolarize, and that's that excitatory effect. So I should mention before I talk about isoniazid, just a brief mention about toxic seizures, since Shahryar is in the audience. I feel like I have to at least mention it, although that's a whole lecture in itself. Toxic seizures are really different from epilepsy. And when we treat toxic seizures, we really want to focus on GABAergic drugs. Right? When somebody has epilepsy, they have a focus in their brain. And a lot of the traditional anticonvulsants, things like phenytoin, carbamazepine, and things, especially the sodium channel blockers, are really focused on stopping spread from that focus to the rest of the brain. But toxic seizures are fundamentally different. Every neuron in the brain is trying to seize. So you need to really globally depress activity. And that's why GABAergic drugs are so important. So really, you want to focus on benzos, focus on barbs, consider propofol. At some point in there, consider, maybe that this is isoniazid, and we'll talk about that in a second. And then think about our other toxic causes that have specific treatments like hypoglycemia and carbon monoxide poisoning. But just remember that we're not going to be turning to our traditional anticonvulsants in people who don't initially respond to benzodiazepines. So when we talk about isoniazid, this is an interesting toxin, and isoniazid is just an example of hydrazines. There are kind of two other clinically important hydrazines, monomethylhydrazine, which is the toxic ingredient in the false morel type of mushroom, Gyrometra esculenta, and also in rocket fuel is hydrazines that cause the same clinical effect as INH, but INH is the one that we're most likely to encounter. And INH has a number of effects, but its most important one is by inhibiting the activation of pyridoxine to pyridoxal 5-phosphate. And that is necessary as a cofactor for converting glutamate to GABA. So you have a patient who comes in who's seizing from INH, and you're giving them lots of benzodiazepines, and benzodiazepines work by enhancing GABA activity. But if there's no GABA to bind to the GABA receptor, then that enhancement doesn't work. It requires GABA to work. And so when you give that pyridoxine to these patients, they're able to suddenly convert glutamate to GABA, and then they will have an effect of the benzodiazepines that you've given. In terms of other things that act on the GABA system, we think about GABAergic drugs like ethanol are going to kind of shift that balance towards GABA, kind of depress mental status. That's with acute ingestion. In people who chronically use a GABAergic drug, they're going to get accommodation, tolerance, and that's also linked to dependence. So what happens is you start to upregulate your glutamate, you downregulate your GABA receptors. You also change the population of GABA receptors. There's different types of GABA receptors that are made up of different subunits, and you get different GABA receptors that are less sensitive to GABA itself. And so all of those things mean that you need to have the alcohol there just to be normal. So you're kind of relying on the chronic presence of alcohol to maintain that equilibrium. And then when the alcohol goes away or the other GABAergic drug, you have that excess of glutamate and excess of excitation. And that's the withdrawal state that we see from ethanol or other sedative hypnotics. All right, let's transition a bit to the spinal cord and neuromuscular junction. So in spinal cord, glycine is the main inhibitory neurotransmitter. It's kind of like the GABA of the spinal cord. And it also is a chloride channel linked receptor. There's two important toxins that affect the glycine synapse, strychnine and tetanus. Strychnine is from the Strychnos nux vomica plant. Strychnine is not very commonly encountered these days. It had been used medically in the past. These days, its main role is as a chioticide, the bottom right picture. And the tetanus toxin is produced by the Clostridium tetani bacteria that live in the soil. And that's something that we're potentially probably unlikely to encounter in the US, but it is something that we worry about and that are often giving prophylaxis for. Just comparing strychnine and tetanus, and you'll notice that this diagram actually is about botulinum toxin, which is Clostridium botulinum as opposed to Clostridium tetani, but it's really exactly the same mechanism of action. The only difference is that the botulinum affects acetylcholine, and the tetanus affects glycine. And the mechanism of action is basically through inhibition of these snare proteins that are involved in fusion of the synaptic vesicle with the wall of the neuron and release of neurotransmitter. So it prevents release of neurotransmitter by preventing that docking of the synaptic vesicle with the cytoplasmic membrane. So for botulinum, it does that with acetylcholine-producing neurons. For tetanus, it does it with glycine-producing neurons. Strychnine is a more simple mechanism of action. It basically just blocks the glycine receptor. So clinically, they look very similar, one through decreasing release of neurotransmitter, one through blocking the effect of that neurotransmitter. So what does that look like? Does anybody know the term for what we're seeing on the bottom left? Yeah, epistotonus. So this is when you lose that inhibition of the spinal cord, you get increased muscle tone throughout the body, and that's called epistotonus, and that's that diagram on the left. There's a term for the facies that's seen on the top right. Yeah, rhizus sardonicus. So that's the same thing occurring in the facial muscles. This is extremely painful. It's a really uncomfortable thing for the patient. And so when you have a patient that is actually at this stage of the illness, which is something I have not seen at the bedside, I don't know if anybody here has. Any of our senior faculty, you've seen one? Yeah. Yeah, it's very uncommon. But when you see it, the patient is extremely uncomfortable, and they generally are going to need intubation and mechanical ventilation, benzodiazepines, and neuromuscular blockers to prevent downstream that effect of the stimulation of the muscles so that it can relax the muscles. If you are dealing with tetanus, you want to give tetanus immunoglobulin in these patients as well. So now let's look at neuromuscular junction. So when you have impulse coming down your presynaptic neuron, you release acetylcholine into the synapse, it binds to your postsynaptic receptor and causes depolarization of the motor end plate. And that is what causes contraction. And things that can interfere with that, botulinum is going to interfere with acetylcholine release. Curare and non-depolarizing neuromuscular blockers, things like vecuronium, rocuronium, cisatracurium are things that block acetylcholine receptors. Curare is a botanical product. The Strychnos toxifera is the botanical source of curare. And then we have our depolarizing neuromuscular blockers, and that's something that we see with succinylcholine and with cholinesterase inhibitors. And I'll show you the cholinesterase inhibitor example when we talk about the autonomic toxidromes. And then there's sodium channel openers and blockers that don't actually act at the neuromuscular junction, but interfere with neurotransmission and can cause paralysis as well. So this is the exact same slide that we looked at before with Clostridium tetani. Here, it actually is the botulinum toxin that I'm talking about. Basically causes inhibition of release of acetylcholine, whereas curare blocks the acetylcholine effect at the postsynaptic receptor on the motor end plate. So what is treatment? Well, if the patient is already having paralysis, then they're going to need mechanical ventilation. If you can recognize this early as the weakness is first manifesting itself, and botulism typically is going to be a descending kind of paralysis when you see it. So if the person's starting, if you catch it early and people are having cranial nerve abnormalities and bulbar symptoms, then you can give botulinum immunoglobulin. Once the patient's on a ventilator, you're not really going to reverse what's happened at that point. So treatment not for botulinum, but if you have a non-depolarizing neuromuscular antagonist, sugammadex is the reversal agent for those. And I just want to highlight before moving on just how interesting this is, that there's these two parallel Clostridium species that inhibit release of acetylcholine and glycine, respectively. And then there's the plant Strychnos species that block the same receptors and have similar effects between the bacterial and plant kingdoms. Okay. Next, we'll talk about the autonomic toxidromes, so cholinergic, anticholinergic, and adrenergic. So we'll start with cholinergic. There's a lot of cholinergics out there. Most of the ones we're likely to encounter are going to be pesticides, but the military nerve agents are also cholinergic. Some of the things we use medically, like edrophonium and physostigmine, are cholinergic. And this is the calabar bean, which is the botanical source of physostigmine. And in our cholinergic synapses lives cholinesterase, which is actually the most active enzyme in the body. It has to be when you consider that acetylcholine are a neurotransmitter at our neuromuscular junction. So if you want to be able to instantly start and stop movements, you got to be able to get that acetylcholine out of the synapse as soon as it's released. And this is the only neurotransmitter that works that way, right? Every other neurotransmitter, you terminate action by reuptake into the presynaptic neuron. But for acetylcholine, we don't wait for that. We break it down right in the synapse. And so the acetylcholine lives there, and it will has a negative charge that positions the acetylcholine in place, and that has a serine residue that can break the ester bond to make choline and acetic acid. So choline gets taken back up into the presynaptic neuron, acetic acid goes off into the Krebs cycle or something, and you stop stimulating your postsynaptic receptors, and your target organ is able to repolarize, and that terminates the event that occurs when you've released acetylcholine into that synapse. So if something sits on one of the active sites of that enzyme, something like organophosphate, that's going to prevent acetylcholine from getting in there and getting broken down. And so you're going to have more and more acetylcholine in the synapse and more stimulation of your postsynaptic receptors, causing more and more cholinergic effects. There's two types of cholinesterase inhibitors, carbamates and organophosphates. And the main difference between them, besides chemically being different, is that organophosphates have something called a leaving group that breaks off once it's been bound to the cholinesterase for a certain amount of time. And that depends on which organophosphate you're talking about, how long that takes. But once that happens, it is no longer able to be reversed by the oximes, which we'll talk about in a minute. And that process is called aging. So for most pesticides, that's going to be hours. One of the military nerve agents, Soman, has a very short aging half-time of 4 minutes, but that's kind of atypical. Most of the ones that we're likely to encounter are quite a bit longer than that. So in order to understand what you're going to see clinically, you just have to remember where acetylcholine lives in the body. Remember, there's two types of acetylcholine receptors, nicotinic and muscarinic. And the nicotinic are in the ganglia of both the sympathetic and parasympathetic system and in the neuromuscular junction. And then the muscarinic are in the postganglionic parasympathetic and the sweat glands. Right, so there's mnemonics for these, but it's two for each. It's not that much to remember. And then just remember that there's muscarinic synapses in the brain as well. There's a mnemonic that some people use sludge for the cholinergic signs of muscarinic excess. It's kind of rhymey: salivation, lacrimation, urination, defecation. It gets a little redundant at the end. The thing is, it kind of ignores the lethal muscarinic effects of these drugs, right? Because you're not going to salivate to death or lacrimate to death. Maybe it's possible to, without medical attention, to defecate to death, but really the things that are going to kill you are the muscarinic effects on the heart and lungs. Right. So some people call these the killer bees: bradycardia, bronchoconstriction, and bronchorrhea. So you're like drowning in your own secretions is something that can kill you. The nicotinic effects can also be lethal. So fasciculations, weakness, and flaccid paralysis. And this includes your accessory muscles of respiration and your diaphragm. So if you can't breathe, then that also will kill you. So when you have excess acetylcholine at the neuromuscular junction at the motor end plate, you're going to get that excess acetylcholine binding to your postsynaptic receptors, causing depolarization of your motor end plate, and that causes contraction. But it's not organized contraction. It's not like you decided to move your arm and an impulse came down your spinal cord and out through a peripheral motor neuron and stimulated the whole muscle at once. It's this kind of random depolarization of the motor end plate causing this quivering like contraction of the muscle that's called fasciculations. And then ultimately you keep stimulating those postsynaptic receptors and you completely depolarize the motor end plate, and it can't repolarize because you keep stimulating it. And at that point you get flaccid paralysis. That sound familiar? Fasciculations and then flaccid paralysis, something we do to patients a lot. Yeah, so one way to think of the nicotinic signs of cholinergic excess is it makes acetylcholine look like succinylcholine. So there's also cholinergic effects in the brain that are less well understood. You can have seizures, you can have coma. We already said if you can have seizures and coma, those are the kind of two extremes of mental status, so you can probably have anything in between. There's also, at least in an animal model, a depression of respiration that occurs centrally before you actually get paralysis of the respiratory muscles. In terms of making the diagnosis, it's clinical. You can send a cholinesterase level. There's two kinds we can measure: red blood cell cholinesterase and plasma cholinesterase, but those are send-out tests. They're going to take a day or two to come back. And if you have a person who's dying of pesticide poisoning in front of you, you can't wait for that test to come back. You can send it and confirm after the fact, but you have to base your treatment on recognition of the toxidrome. And then again, just consider the cholinesterase levels as a confirmation test after the fact. So what is treatment? So for most EM lectures, treatment starts with A, B's, and C's. Here, if somebody's externally contaminated with something that can get you sick, whether it's a nerve agent or a pesticide, they may need to be decontaminated before you can even begin to take care of them, unless you're wearing appropriate personal protective equipment for that toxin. And decontamination is just take off your clothes and take a shower. That's removing the clothes, glasses, contact lenses, etc. Is going to remove most of the contamination, and then just copious irrigation with water will take care of the rest. In terms of A, B's, and C's, whether somebody needs to be intubated right away or you have time to try your antidote is kind of a bedside decision. Based on the sarin attack of the Tokyo subway, there was a whole bunch of patients with some sort of exposure, a lot of worried well. There was several hundred patients that had some clinical effect, of which meiosis was the most common. There was a handful of patients that wound up in the ICU, of which I think maybe 6 were intubated. So it's uncommon, at least based on that attack on the Tokyo subway. But again, ingestion of a pesticide is going to be different than this aerosolization of a nerve agent in the subway. So again, it's going to be a clinical decision at the bedside. In terms of antidotes, we have 2 major elements of our antidote kit: atropine and our oximes. In terms of those, atropine is a competitive muscarinic antagonist. And our dosing for atropine in this setting is really different from any other setting. So if we think about our bradycardia algorithm for ACLS, where we might give a 0.5 milligram every few minutes up to a maximum of 3 milligrams, you'll never get to an adequate dose for a badly poisoned cholinergic patient with that type of dosing strategy. So typically we're going to use a doubling philosophy. We'll give 1 milligram, then 2, 4, 8, 16, really rapidly getting up to these massive doses that you don't use for anything else. And one pesticide poisoned patient can deplete a whole hospital's atropine supply. Your endpoint is clear lungs. You want to address the muscarinic effects that are going to kill the patient. So once you've enabled good gas exchange, that's kind of adequate atropinization. And it doesn't matter if the patient gets a little tachycardic. Remember, A and B comes before C. So you want to address the gas exchange first by atropinization. And then the other element of the antidote is the oximes, in the US, we have one of these available, Praudoxime or Tupam. This is the Mark I kit, which was the old US military nerve agent antidote kit that contained auto injectors of both of these drugs. We're not going to be using the auto injectors in the hospital setting. We'll be using vials of the medication. And the role of the oxime is as a cholinesterase reactivator. It basically kicks the organophosphate off of the cholinesterase and regenerates the active enzyme. And that only works up until aging has occurred. Once aging has occurred, then the oximes don't work. Diazepam in animal models has an independent benefit on mortality. And so probably through mitigating seizures, which are really not treated by the atropine and the oximes. And then one thing that just kind of makes sense, if one of the things that kills you is muscarinic excess in the lungs, we have an anti-muscarinic that's designed to go straight to the lungs, the ipratropium bromide. This might be particularly important for a mass casualty scenario where you're worried about potentially running out of atropine. This might decrease the amount of atropine it takes to get to clear lungs. So you would never use this by itself, but as an adjunct. Let's look at the anticholinergic toxidrome. There's a lot of anticholinergic things out there. By far, the most common one that I've seen is this one. Diphenhydramine is just a very common overdose for the same reason that acetaminophen is a common overdose. People take what they have, and a lot of people have this in their medicine cabinet. So this is really common, but all of the antihistamines have some degree of anticholinergic effect. The antipsychotics, especially the older ones, butyrophenones, phenothiazines, are all very anticholinergic, but some atypicals also, olanzapine is quite anticholinergic. Antidepressants, and here again, we're not talking about SSRIs and SNRIs, but specifically tricyclic antidepressants are anticholinergic. And of all the anticholinergics out there, these are the most important ones to recognize because these are the ones that are going to kill the patient. In general, anticholinergic poisoning is pretty miserable for the patient. They can't pee. They're kind of delirious. They're uncomfortable, but they typically don't die. But TCAs kill patients, and they kill patients quickly, usually within 6 hours of ingestion, and they're really sick early on after ingestion. So, and also our antidote for anticholinergic poisoning is contraindicated in TCA poisoning. So when you see an anticholinergic, your first question to ask yourself is, could this be a TCA? And how do we answer that question? Yeah, EKG, right? So we're going to be looking for that QRS interval. If the QRS is under 100 milliseconds, it's not any consequential TCA overdose. You can also look for that terminal 40 millisecond right axis, which the absence of that has a negative predictive value of 99%. So yeah, if you do identify TCA poisoning by EKG, then stop thinking of it as an anticholinergic, start thinking of it as a TCA and focus on the potential cardiac effects of TCAs and giving sodium bicarbonate to treat the QRS widening. Some of the things we use to dilate the eye are anticholinergic. And then there's a number of anticholinergic plants. This is Atropa belladonna. This is the plant from which atropine is derived. And this one is Datura stramonium, also known as Jimson weed. This grows throughout the continental U.S. Within the summer months, you can find it growing within a few blocks of Kings County. And it produces these spiny pods that contain seeds. And kids will hear through the grapevine or maybe read on the internet that they can eat a bunch of these seeds and hallucinate. And it's not the kind of hallucinations that they're looking for. Like most recreational hallucinogens or serotonin-mediated hallucinogens. Anticholinergic hallucinogens tend to be kind of small versions of things, what's called Lilliputian hallucinations. And you'll see people kind of like picking at the air and what's called wool gathering behavior. It's not particularly pleasant. Remember, serotonin is the happy neurotransmitter. This kind of isn't that. But this is a common question on the PEDS boards. If you get a group of adolescents coming in looking anticholinergic, think of Jimson weed as the potential source. So I talked about the military nerve agents for the cholinergic toxidrome. There's one military chemical weapon that was developed by the U.S. called BZ that was an incapacitating the agent. The idea is instead of killing the enemy, you make them hallucinate so they're ineffective in combat. And so we had developed this. It was all decommissioned in 1998 after signing the chemical weapons ban. So when we talked about the when we talked about the cholinergic toxidrome, we talked about the nicotinic effects and the muscarinic effects. But for the anticholinergic toxidrome, there's no anti-nicotinic part of it, and it's best thought of as the anti-muscarinic toxidrome. So no effects on the ganglia, no effects on the neuromuscular junction. It's basically anti-parasympathetic, anti-sweat glands, and then there's the central effect in the brain causing delirium and hallucinations. So there's this mnemonic from First Aid for the Boards. I think it's dumb, but if it helps you, that's great. One of my fellowship director, Lewis Nelson, used to say, just make everything a pepper. If that helps you, again, great. I think it's easier to just remember anti-parasympathetic, anti-sweat glands, and delirium. And again, when you see this anticholinergic toxidrome, you're going to diagnose it by recognizing the pattern of signs and symptoms. Putting in a Foley catheter is useful to check for urinary retention, and then always get an EKG to screen for tricyclics. Treatment, A, B's, and C's. I guess if there was like a BZ attack, which shouldn't happen since it's all been decommissioned, but then you might potentially have to worry about external decontamination. But in this case, the decontamination that we're talking about is GI decontamination. So A, B's, and C's first. It's rare for these patients to need to be intubated if it's not a tricyclic. And then GI decontamination, if they're able to safely take activated charcoal, they're protecting their airway and their mental status allows it, that's reasonable. And then some of these patients are really delirious and they might need to be sedated or even restrained. And then we consider our antidote physostigmine, which is a carbamate cholinesterase inhibitor and will basically overcome that cholinergic blockade. So who gets FISO? You have to have ruled out TCAs because giving physostigmine to a person who's TCA poison can cause asystole. So luckily, we have a good way to identify those patients, and that's the electrocardiogram. If the electrocardiogram has a normal QRS, it's not a TCA, and you don't have to worry about that. And then you have to have both central and peripheral signs of anticholinergic poisoning. So you're going to give that to those patients. Now, there is a limited access to physostigmine because the last U.S. manufacturer of physostigmine stopped making it. The FDA has allowed importation of the German product, and we're in the process of obtaining that at Kings County. I haven't done it at Downstate yet, but we had no physostigmine for a while, and now we're going to be having it back soon. In the meantime, if you have a patient like this, there is some data for using rivastigmine, which is a little bit suboptimal because it's an oral agent instead of IV. But if it's the only thing that you have, it's an alternative. All right. Next, adrenergic toxidrome. Things that are adrenergic include cocaine, include the amphetamines, arylhexamines like PCP, ketamine, dextromethorphan, methylxanthines like theophylline and caffeine. And here it's a little bit different than the cholinergic system because it doesn't matter whether you're talking about the sweat glands, which use acetylcholine, or the rest of the sympathetic system, which uses norepi. It's all stimulated because it comes from stimulation of the brain, increasing sympathetic outflow. So it's just your fight or flight response. Everything's revved up. People who are going to die typically die from hyperthermia, tachydysrhythmias, bleeds, or ischemic complications. The hyperthermia is particularly well established for cocaine. This is a study from the New York City Medical Examiner's Office that showed that cocaine deaths tend to spike when you have a temperature outside that's more than 89 degrees. When we treat these patients, you want to address the vital signs, right? Those are the things that are going to kill them, and treat hyperthermia with every bit as much urgency as you would hypotension or tachycardia, because when you get that patient with a temperature of 108, 110, 112, their proteins are literally cooking, and you don't have a lot of time to bring that temperature down before they're doomed to go on to multi-organ system failure in the next few days, even if you can survive the acute episode. So an ice bath is the best way to do this. Use one of the body bags that we use for deceased patients. They're watertight, and you just fill it up with ice and water. Have a rectal probe in the patient so you can take them out of the ice bath when they get down to 102. You want to calm these patients down. Benzodiazepines are the best way to do that. And then check for rhabdomyolysis, which is a common complication. I'm not going to spend too much time on this diagram. I'm going to forward you the PDF of this lecture so that you can look at it on your own to just highlight the differences. People tend to confuse adrenergic and anticholinergic and just kind of the main things that are going to be different are the mental status, the reactivity of the pupils, urinary retention, and the skin are going to be the main things that are going to help you distinguish between them. And some people confuse anticholinergic and cholinergic mostly by just switching them, and you just have to remember which is which. A few minutes on toxic neuropathies. In general, leads, organics, nitrous oxide, lead, mercury, arsenic, and thallium are basically all metals that can cause neuropathies. A lot of organic compounds, toluene, vinyl chloride, carbon disulfide, and N-hexane are examples, and nitrous oxide. Lead neuropathy is a bit different than the others in that it's primarily a sensory neuropathy, primarily a motor neuropathy, and the classic is wrist drop. You lose the ability to pronate and supinate, and it's this motor neuropathy that manifests first in the upper extremities. Mercury can cause both sensory and motor neuropathy, as well as it progresses, can cause ataxia. You can see here this patient was asked to draw this, to kind of trace over this sine wave, and you can see inability to kind of do that because of the ataxia. And this is a patient that was poisoned by arsenic. He had been ingesting this rat product, this rough on rats, the rodenticide that was arsenic containing, and he had developed this sensor motor neuropathy also from that. This is a patient that Bob Hoffman took care of at Bellevue. So just to sum up, GABA inhibition and glutamate is excitation, and that balance controls coma versus seizure. Glycine is the GABA of the spinal cord. Neuromuscular junction dysfunction can occur through preventing release of acetylcholine, through blockade of the receptor, or depolarizing effects. In terms of distinguishing between your autonomic toxidromes, it's vital signs, mental status, pupil, skin, bladder, bowels is the main things you're going to focus on physical exam. Metals and organics cause neuropathies, and removing people from exposure for those neuropathies is going to be the most important treatment for them. Any questions?